performance assessment is part of performance achievement. That means if you don't know how well you are doing, then you can't say for sure you are doing it.
It is like we have been planning blindly when we really don't know what is on the ground.
Monitoring is vital, it's lifeline, because whatever we implement, unless you don't monitor, everything is going down the drain.
The usefulness of data relies heavily on the frequency with which the data is collected, the frequency with which it is analyzed and actually used in decision making. And I think that's one of the powerful advantages that a technique such as lot quality assurance sampling, which has been used for many, many years in industry, can actually be used in the public health field.
LQS can help me identify at a local level where services are delivered, where those problems exist, and can help me focus on the problems to understand what the reasons are that they are problematic. That's how we can save lives.
LQAS is one of very few methods that provide data at the district level.
It is rapid, and because you're using a small sample size, it's relatively cheap.
It's a very useful tool to see where you're going. You're not working in the dark.
What it does is to provide up-to-date, population-based, systematically collected data with a focus on identifying areas, small areas within the districts which need special attention.
So within the catchment, within the district, within the region, you see the variation across the indicators, across the sub-districts or the supervision areas.
It's a classification technique. You classify to the right hand or to the left hand, reached a target or not having reached a target.
You're tracking both getting this very participatory, engaged, use-oriented data at the ground for decision-making at that level, but then just through the same data, you can then aggregate it up and get the kinds of things that people at higher levels or state officials or district officials or us at the foundation, what we need to understand whether things are on track.
There are many countries that have used it over time. Uganda probably has the showcase example of LQAS in Africa today. It's been in operation on an annual basis since 2003.
Right now, about 3/4 of the 111 districts in the country have participated in this activity.
So we use district teams, and we take them through the entire cycle of LQAS. We train them, they do the data collection, they do the hand tabulations. Actually, most of the planning processes is based on data manually generated by the district teams.
The results will help us to sit together as a district and we plan.
We now work together. From the results, we sit together and agree on the way forward, on the findings, based on facts.
What they learn from us is important, but once they learn from each other is even more important because they kind of see it as, their peers have done it, so why can't they?
It's a very strong motivation to see that we are at this level of service delivery. Now we have done this intervention as a result of the previous LQAS. Now we have reached somewhere. It's going to be a very big motivation and encouragement to our people.
By our choice of the data collector, which are already working in the local government, we use their expertise to develop the capacity of the people within the local system.
If LQS is institutionalized and even further gets into the support supervision mechanism for the districts, then the costs of implementing LQS will drastically reduce.
Now that a few universities have already integrated it into their curriculum, into training, that means somebody is coming from the university with a degree, but part of that degree is skills to do LQAS.
Both staff and students were excited about the approach, and many students are already using it actually to do their dissertations.
LQAS is a desired methodology. So when our students go and join those programs out there, they don't start at zero.
This should apply to the whole country, Uganda.
working with our development partners and some support, we can be able as a government to lead and introduce this methodology to all our local governments, especially at sub-county level, the lowest local government, so that they can be able to use this evidence and be able to track the changes in lives of the people.
India is a very interesting success story. The reason is because of the scale. I think what India offers is the chance to show how a country can move to developing an LQS with focus on excellence.
In 2009 and 10, DFID supported Liverpool School of Tropical Medicine to introduce LQAS to Government of Odisha through their malaria program. To begin with, we started with 4 districts. 3 were our intervention districts and 1 was our control district. Over a period of time, we could demonstrate some real improvement in the coverage data because of LQAS. And given the success in the initial years, we decided to scale it up to 9 districts. And now it seems Government of Odisha has institutionalized it as a part of its overall system.
We have been using LQAS as a methodology, as a tool, extensively in the National Vector-Borne Disease Control Program, especially in the areas of malaria.
It's a very good tool which gives us analysis on the spot, and you can use this tool for taking corrective actions in a very, very short time.
What are the gaps? Where are the weaknesses? And then the corrective measures can be taken at that level.
The malaria death case has come down, which was 39 in 2010, and gradually in 2013 it was 1.
This LQS is not a standalone program in Odisha Malaria Control Program. It is integrated with the program, the same manpower and the same time schedule, and that is why I can see that such program in the long run can be integral part of any public health program.
It makes people smarter, whereas the other surveys which the periodic studies etc., it might make people knowledgeable. But we want smart people at the level where action is happening.
The thinking now of the way of looking at things in terms of health service delivery has changed.
In the past, we tended to move blindly.
But now we can plan, we can make smart work plans, we can make work plans which are evidence-based, which are very scientific. Even in this 21st century.
There is no reason to limit the scope of using LQAS as a tool or a methodology.
It is my hope that now that there is a track record for LQAS, that this methodology will be taken up by the various international development agencies that are supporting public health across the world. And if there's a commitment on the part of these development agencies and the countries that they support to actually use it systematically, I think that we could significantly enhance the reach of our monitoring and evaluation efforts in public health programs in developing countries.
So far, so good. I have a feeling that we are on the right track. Yeah.